Good afternoon. Thank you for joining us for this webinar today on hepatocellular carcinoma, epidemiology, surveillance, and management. My name is Mary Owen, and I'm a member of the Tlingit Nation and a family physician with the Leech Lake Band of Ojibwe and the director of the Center of American Indian Minority Health at the University of Minnesota Medical School. Also on the webinar today is Dr. Brian McMahon, a clinical liver specialist or hepatologist, and the scientific program and clinical director of the Liver Disease and Hepatitis Program for the Alaska Native Tribal Health Consortium in Anchorage, Alaska. He's been active in research in viral hepatitis A, B, and C, as well as other liver diseases among American Indians, Alaska Natives for over 30 years. He also was on the Institute of Medicine committee that published recommendations for hepatitis and liver cancer in 2010. As a family physician for my own tribal nation in Juneau, Alaska for several years, I consulted Dr. McMahon often for assistance with my patients with advanced liver diseases. So I'm happy you could join us today in reviewing liver disease in Indian country. I also want to remind you to send in your questions as we move along, and we'll leave time to address all of them at the end. And both Dr. McMahon and I would like to thank the American Indian Cancer Foundation for inviting us to talk on this critical topic this month. So, miigwech, gunchish. Neither Dr. Go ahead and advance, please. Neither Dr. McMahon nor I have any conflicts of interest. Advance, please. The goals of this presentation today are to discuss the global incidence of hepatocellular carcinoma, changes in incidence and etiology in the disease over the past couple of decades, major causes of liver cancer and cirrhosis, as well as the risk factors and etiologies for developing hepatocellular carcinoma. And then finally, we'll discuss what must happen to decrease the incidence of this deadly disease. Go ahead, please. So this slide here illustrates the incidence rates of liver cancer across the United States from 2008 to 2012. And you can see here that the blue areas are those with the highest rates and are concentrated mostly in the Pacific states, those states on the southern border, and a few states in the Northeast. Go ahead and advance. Dr. McMahon will jump in if he has any other comments to add as I'm going through these initial slides, and then he'll come on later in the program. This slide, using data again from 2008 to 2012 and comparing differences among ethnic or racial groups, reveals that the highest incidences in American Indians and Alaska Natives and Asian Pacific Islanders. And you should note on this slide that, or note now that most of the disease in Asian Pacific Islanders is from hepatitis B virus, whereas most of ours in this country is from hepatitis C virus. Go ahead, please. And here we're looking at the incidence and 5-year survival rate from hepatocellular carcinoma in the United States. And you might get the impression on this slide that things are getting better as far as survival rates, but when you consider that we're still seeing a survival rate of only 12% for hepatocellular carcinoma, it remains an extremely lethal disease. And in fact, probably the most lethal when you consider that it is the only disease that is has an increasing mortality rate, unlike any other cancers in this country. In fact, there's a tripling of the incidence rate just in the last couple of decades, and most of this is because it's diagnosed when the disease is advanced, which is a key point in this talk today. Next treatment, please. Next slide, thanks. So here are the primary diseases leading to hepatocellular carcinoma and their incidence among patients with liver cancer. Unlike hepatitis B, or unlike hepatitis C, patients with hepatitis B don't have to have cirrhosis to advance or to have increased incidence of hepatocellular carcinoma. And you can see those with cirrhosis on top of the hepatitis B virus have a 3 to 8% incidence of developing hepatocellular carcinoma. Patients with cirrhosis from hepatitis C have a 3 to 6% incidence in developing hepatic cellular carcinoma, and primary biliary cirrhosis 3 to 5. We don't have good data on alcohol, NAFLD, non-alcoholic fatty liver disease, or autoimmune hepatitis. Next slide, please. This is a slide showing a study done in the United Kingdom where over 3,000 patients with cirrhosis were followed for over 10 years. And for those, you can see that the overall incidence of developing hepatic cellular carcinoma was about 4%. And these numbers are probably similar to what we see in our own country. The incidence of developing cancer was highest for those patients with viral hepatitis at 4%, and hepatitis from autoimmune and metabolic diseases at 3.2%, And here you can see that the incidence of hepatocellular carcinoma development in patients with alcoholic hepatitis is lower, and this is probably due, or we know it's due to the fact that patients with alcoholic hepatitis tend to die from that disease before they develop hepatocellular carcinoma. Next slide, please. So decreasing morbidity and mortality in native patients from hepatocellular carcinoma and cirrhosis. How do we do that? First, we need to identify all those patients with underlying liver disease early on. And that means screening folks with metabolic disorders, diabetes, autoimmune diseases, IV drug users, and alcoholism. All those patients, screen them for liver dysfunction. Additionally, Dr. McMahon just informed me that the American Public Health Task Force is about to come out with recommendations to screen everyone, not just baby boomers, for hepatitis C once in their lifetime. So once patients are found to have liver dysfunction, we need to determine the cause and begin treatment as soon as possible to prevent progression of the disease. Patients at risk for developing hepatocellular carcinoma, including anyone with advanced fibrosis, defined as F3 or F4, which we'll talk about in a second, and those with hepatitis B should begin surveillance programs to catch the disease earlier. Catch hepatocellular carcinoma earlier and then get it treated earlier. And of course, start those with hepatitis cellular carcinoma on effective treatments as soon as possible and promote research to find better prevention and treatments for the disease or the cancer. Next slide, please. This slide shows the proportion of Alaska Native and American Indians who have liver conditions that put them at risk for hepatocellular carcinoma. American Indians and Alaska Natives have similar rates, except for they're in the hepatitis B. In Alaska, we do have higher rates of that. Although the rates of alcoholic liver disease are unclear, we do know that the rates of alcoholism, particularly binge drinking, are increasing across not only the United States, but across the world. Next slide, please. This slide's really a reiteration of the previous two slides. Again, other than hepatitis B, American Indians and Alaska Natives have similar risks and incidence profiles for hepatocellular carcinoma and all of its causes. I do want to highlight, though, the importance of assessing the level of fibrosis that's noted on this slide. This has to be done to determine their risk for developing having advanced disease and developing hepatocellular carcinoma, and then whether or not to begin them on surveillance programs. Next slide, please. So here are more specifics on finding patients who are at risk for liver cancer. Screen all persons who are born in endemic countries for hepatitis B. Again, all patients for hepatitis C. And for any of those patients who are positive, determine their level of fibrosis. Recently infected patients with hep C are at lower risk than baby boomers, of course, for developing advanced disease. And screening, and also don't forget to screen people with alcoholic liver disease, although again, they seem to be less likely to go on to develop hepatocellular carcinoma because they die earlier from the liver disease. Next, please. Risk factors for developing hepatocellular carcinoma for patients with hepatitis V include viral load, genotype, family history, and whether or not they have cirrhosis. But again, this is primarily for those Alaska Native patients, not so much in the lower 48. Next slide, please. And this slide illustrates the cost effectiveness of surveillance screening for hepatocellular carcinoma. A former analysis of hepatitis B virus demonstrated that surveillance became cost effective when the patients with hepatitis B virus who developed hepatocellular carcinoma exceeded 0.2%. And we know that the rates of developing hepatocellular carcinoma in patients with hep B who are Asian, Alaska Native males, over 40, females over 50, and those who have a family history of hepatic cellular carcinoma, as well as patients with cirrhosis, have incidence rates of 2 to 4%. So they easily meet the cost effectiveness measures. Next slide, please. Thank you. Risk factors that lead to the progression of hepatitis C virus and put people at higher risk for developing hepatocellular carcinoma are listed here. The strongest factor is heavy alcohol use. Males are at higher risk than females. HCV genotype 3 versus 1, as we'll see in a minute from on the next slide, don't change yet. I want to point out that what is not associated with progression here, and that's increased viral load for hepatitis C. And also the presence of core antibody without antigen. those folks are exposed, but they do not have the disease, the active disease. Next slide, please. And this slide just demonstrates what we just covered. You can see that older patients, those with genotype 3 versus 1, and males all have higher risk for developing hepatocellular carcinoma. Next slide, please. And this slide shows that the further along the cirrhosis is, or the higher rate of fibrosis, as in the far, on my screen would be the far right, the further out they go, the more deadly or the higher incidence of developing hepatocellular carcinoma and eventually of dying before or as the disease progresses. You also should see that on the far left, where they have no fibrosis, that there is, even at the 10-year mark, they still have not developed hepatocellular carcinoma. So there's a significant difference between the no fibrosis and F3 or high levels of fibrosis. Next slide, please. Non-alcoholic fatty liver disease. Though we don't know the incidence of non-alcoholic fatty liver disease progression to hepatic cellular carcinoma, there are some studies that suggest that an increased risk for developing liver cancer for patients with cirrhosis, no matter what their level of fibrosis is. And further, once cirrhosis is well established, patients may not be able to reduce their risk of hepatic cellular carcinoma by lifestyle changes, so need to be started earlier. Next slide, please. So what specific measures might reduce the risk of hepatocellular carcinoma? First, universal vaccination for HBV starting at birth, diagnosis of HBV in asymptomatic people and getting them started on treatment, diagnosis of cure of hepatitis C, which we can do now, and then programs to reduce the number of people getting hepatitis C, such as opioid treatment programs and clean needle exchanges, and addressing and finding ways to decrease obesity, which of course will lead to the NAFLD. And then addressing other conditions like hemochromatosis, autoimmune hepatitis, primary biliary cirrhosis with early diagnosis and treatment. Next slide, please. Epidemiology of hepatocellular cancer is also changing. With universal screening and treatment of hepatitis C in all patients, hep C will be less a factor in high-income countries and in high-income countries like our own. There's also a steady decrease in hepatitis B virus incidence around the world. NAFLD, though, is increasing and could become the #1 risk factor for hepatocellular carcinoma. Alcohol abuse, again, is increasing around the world, so we'll have to see how that one plays out. Next slide, please. And this slide shows the rates of hepatocellular carcinoma incidence by etiology. And you can see that the etiologies with increasing incidence here are non-viral, such as NAFLD and hepatitis, NAFLD and autoimmune hepatitis, and then also hepatitis C. Next. So a primary take-home from this presentation is the importance of assessing the level of fibrosis in your patients with liver disease. And there are several non-invasive tests that you can do, a couple which we'll talk about in a second. Those that you can do yourself are about as good as the commercial markers. And Dr. McMahon will take you through the imaging assessment tools and biopsies. Next slide, please. Here are two of the non-invasive formulas that you can pull up on your smartphone even. You just insert the stated labs and you have a value. And tests are very helpful for about 50% of your patients. Unfortunately, the tests are neither of the tests is very sensitive. So about 50% of your patients will either be very high or very low risk. Those with high risk will be referred on, and those with low can just be managed for their risk factors and then periodically surveyed. Intermediates, you'll likely end up having to send them for more definitive evaluation of their degree of fibrosis. And that leads me to turn it over to Dr. McMahon. Next slide, please.
Thanks very much, Mary, and thanks, Ashley, for inviting me. So those non-invasive markers that Mary was talking about, basically, if you just go on your smartphone and on your you just put in NAFLD fibrosis score, it'll pop up several sites where you can actually get that NAFLD fibrosis score, and you can actually put that. I have that actually as an app on my phone, and then you can plug in all the numbers for a patient that has the metabolic syndrome and find out if they have a lot of fibrosis or no fibrosis. And then if most of them are going to fall as indeterminate, so you'll have to do more, but at least that's the first step that's going to, as Mary said, it's going to help you figure out very quickly in just a matter of a few minutes or 1 or 2 minutes if there's a lot of fibrosis or there's no fibrosis with a 90% accuracy. And then if you can't, then you've got to go on to another method. So the second thing that we use is something called transient vibration controlled transient elastography. The commercial name of this is FibroScan. It's made by a company in France. It's available in the United States. And it's becoming very popular, and it's really resulted in not having to do liver biopsies in an awful lot of patients, including it's rare to do liver biopsies by anybody that has access to this in patients with hepatitis C anymore. We used to have to do those biopsies because we couldn't get patients funded if they didn't have a lot of fibrosis, at least in Alaska. I don't know what the requirements are in Minnesota or where you're at, but in some places, Medicaid wants them to have either F3 or F4 fibrosis before they'll fund them for the treatment with the drugs. And in Alaska, they've dropped all that, and now we started out that way, but now anybody can get treated for hepatitis C, even regardless of the fibrosis, and even if they're using drugs or alcohol, they still can be treated if they're reliable and they come in and get the medication. So what transient elastography is that it uses a powerful ultrasound wave that's shot into the liver. We have to do like 10 to 15 shots to get 10 good readings. It's very simple to learn. It takes a 2 hour, you learn it in a 2-hour course. You can't screw it up because the machine will not allow you to print out the reading if you do it wrong. And it can be done in our hospital. It's done by nurses and by clerks. So that our two clerks who answer the phone and schedule, they wanted to get involved in being involved with patients, so they took the course, and they are actually our two best fiber scanners. So this is something you don't really need a lot of technical skill to do. The more you do, the better you get. And better you get means that you get more readings that the machine allows you to keep rather than throwing them out. It also measures how much fat is in the liver using a software package called the CAP, and it measures it in dBs per meter, and this correlates with how much fat. So with ultrasound, you sometimes get, when you do ultrasound, you'll see them come back from the radiologist saying the liver is dense and there's probably replaced by fat. Well, you have to have a third of your liver involved with fat, a third of the cells, in order for an ultrasound to be able to read fat in the liver, whereas this can read fat up to as low as 5% of cells, liver cells having fat in them. So this is a very good technique, but it's about $120,000. Radiologists don't want it. They don't get paid for reading it. It's read by clinicians. It's a clinical tool. So they will tend to go against buying this and putting in their unit. But any major university or referral clinic should have a FibroScan machine. We also have a portable FibroScan that we take around to the villages and to the regional hospitals and do FibroScan there. So it's a good tool. There's a pediatric probe. You can do it all the way down to kids who are overweight, all the way down to age 2 if they'll hold still long enough to give the 10 shots. It feels like somebody's stumping you in the chest. There's no radiation. There's no danger at all from the FibroScan. Next slide. So here's what it looks like. You see the probe is shooting in this very powerful wave and making a measurement, and then it gives you this, it tells you whether or not there's fibrosis present or absent. It's really good for the absence of fibrosis. It's 90% accurate, and also for the presence of cirrhosis or severe fibrosis, it's about 70% accurate. And also measuring the amount of fat with the CAP score, you can tell whether or not they have a mild amount of fat, a moderate amount of fat, or a lot of fat in their liver from this. So it gives you a lot of information. It takes only about 20 to 30 minutes, and the patient only has to fast for 3 hours to have a FibroScan. Next slide. So it, as I mentioned, has really good sensitivity and specificity if there's no scarring or there's a lot of scarring. In between, it'll tell you there's some scarring, but it can't tell you how much scarring there is. So the other thing that you can use if you can't get a good reading with FibroScan, the next step is called magnetic resonance elastography, or MRE. This is done on a regular MRI machine, but you have to add some equipment and some software. It's about $55,000 to add that in, and we actually have that at our hospital, and pretty much every university or big hospital has this. It's no better than FibroScan at the low end, but it is better at the high end than FibroScan. One of the reasons that FibroScan is not 90%, is only about 70% at the high end, is because if you have a lot of fat in your liver, that can raise your scarring score, your kilopascal score, by anywhere from 1 to 3 kilopascals. That can take somebody from a small amount of scarring to advanced fibrosis, just because there's a lot of fat in the liver when they really only have a small amount of scarring. So that last part is, it is now available at our hospital. That's wrong, I should have taken that out. Okay, next slide. So here is MRE. There's a driver that sits over the patient's liver. We'll show you a picture of that. And then it gives you this wave, and it can tell you how much scarring is in the liver. So the next slide will show a little more detail. Here's what the driver that sits over the liver looks like. Next slide. And here's a patient lying in the MRI machine with this little thing placed over the liver. And then you can see there's a mechanical driver on the outside. And then the radiologist turns that on and gets the reading. It only takes about 10 or 15 minutes in the MRI scanner, not like a full MRI. So it's quick and to do, and it should be a lot less expensive to do that. Next slide. And here's how it reads out. So on the F1 means there's a little bit of scarring there or no scarring. F2 means there's a moderate amount. F3 means there's a lot of scarring. And F4 means cirrhosis. And the machine will interpret the colors for you and give you an actual reading in kilopascals to say this patient has cirrhosis, this patient doesn't have cirrhosis. Next slide. It also will measure, just like FibroScan, it can measure how much fat's in the liver, and it will interpret these colors for you and say there's a lot of fat, there's not much fat. It'll give you a percent. You can see over on the left, that particular patient had 21% fat in the liver, and the next patient had 17% fat. Next slide. So the next question is, when we identify somebody with F3 or F4 fibrosis with advanced fibrosis or cirrhosis, those are the people who are going to need surveillance for liver cancer in order to find those tumors early on. Everybody with cirrhosis, everybody with a family history of liver cancer that has hepatitis B, and then for hepatitis B, men over 40, women over 50. And then we have it's not effective for children. So sometimes we get calls saying, oh, I've got a child with hepatitis B. When do I start checking for liver cancer? Well, it's not you don't need to check kids for liver cancer with hepatitis B unless they have an unusual genotype, that one of the genotypes we have in Alaska. Yeah, next slide. So everybody, if you identify them with F3 or F4 fibrosis, for example, you use those non-invasive markers, a FIB4 and the NAFLD fibrosis score, and it says they've got advanced fibrosis. They're going to need liver cancer surveillance every 6 months for the rest of their life. So you start out with the Aspirin and the FIB4. And again, you don't need to remember these formulas. All you got to do is go on your smartphone and just type in APRI in your search engine, and it'll take you to many sites where you can click on them, and then they'll give you the APRI, and you just punch in the numbers, and then they'll interpret it for you and give you the score. Same with FIB4. And they'll tell you whether that score is advanced fibrosis or not, or no fibrosis. Then if those work well, or if they don't work well, which they won't work well about half the time, then you can do, there's commercial tests, FibroSure, FibroTest, FibroSpec 2, but they're about $300, and they're not that much better than the free ones. So we don't waste our money on the commercial tests unless there's something that we need to get a score on in order for Medicaid, when we were in a Medicaid state that wouldn't fund treatment of Hep C unless they had F3 or F4. We used everything to try to get them funded. And I don't know what in your state what the rules are, but you know, as you know, some states Medicaid programs won't pay for anybody unless they have advanced scarring in their liver to get the drugs, to pay for the drugs. A liver ultrasound occasionally can be helpful if you see that if you ask when you get an ultrasound of the liver, you should always ask for a portal vein flow study. It's no extra cost. They'll measure the flow through the portal vein. If it's going in the right direction, then you don't have portal hypertension. If it's going in the wrong direction, you know you've got cirrhosis because there's portal hypertension. And then, of course, we would go with FibroScan followed by MRE, and then liver biopsy if we can't figure it out in order to find out if there's a lot of scarring or not. And we don't have to do that very often, except in patients with NAFLD. In hepatitis B and C, we rarely have to do a liver biopsy. Next slide. So if you click on this, you punch this into your smartphone or your computer for free. You can download the latest US guidelines by the Liver Society, and it'll tell you a lot of this information that I'm giving you now. But the guidelines say that if you have F3 or F4 scarring, advanced fibrosis or cirrhosis, that patient should have ultrasound of the liver and alpha-fetoprotein every 6 months forever, and insurers, including Medicare, Medicaid, will cover this. So you just need to get your patients in and get them screened every 6 months. Next slide. Okay, so how good are these tests, these radiographic tests? Well, ultrasound is ubiquitous. It's everywhere. It's non-invasive, no side effects. It's low cost. The disadvantage is that it's highly operator dependent. So like in Alaska, for example, we have really good ultrasound techs at our hospital, and they pick up a lot of small tumors. When we move out to the regional clinics and hospitals, and they have ultrasound techs there, they're not experienced at picking out liver cancer tumors, and they'll miss cancer tumors. So it really depends on the operator's skill. The nice thing about it is that it's low cost, but it also doesn't work very well in obesity. And in other disease states, that there's another disease going on in the liver, sometimes it's hard to find small tumors. Now, I'm going to show you about one of the most important things is that you need to know how to order a CT scan if you're looking for liver cancer. A regular non-contrast and contrast CT scan is very ineffective at finding small tumors. You have to use a multi-phase CT scan. I'll show you the example of that and why that's important. But the multi-phase CT scan has high sensitivity, but then if you have to do that every 6 months, there's a risk of high radiation over time, and it's also costly. MRI is very sensitive. It gets very good resolution, but its ability is limited. It takes a lot of time, and it's also, it takes more time, and also it's very high cost. And if you use gadolinium as your contrast agent, you can accumulate gadolinium, and that can be potentially toxic over time. Next slide. So here's the downside of surveillance. Just like in breast cancer, we all know that when you do breast cancer surveillance, you pick up a lot of little lesions in the breast. And about half of those lesions or so turn out to be breast cancer, but half of them might not be breast cancer. And so there's a lot of procedures and biopsies done and removal of these small little lesions in the breast that turn out not to be cancer. Well, the same thing is the story in liver disease. If you find a lesion in liver disease, it may or may not be cancer. Sometimes we have a really good probability that it's cancer based on the way it appears, and I'll show you examples of that. But in this particular study, where they followed patients with cirrhosis, very high risk of getting liver cancer for 2 years, and then 26% of them over that 2 years had a lesion that could be liver cancer. And then it turned out that only about a quarter of those that had the lesion, it turned out to be liver cancer. And I'm going to talk to you about the Milan criteria. The Milan criteria is what is the criteria for getting a liver transplant. And I'll show you that later. But that's potentially curable. If you meet the Milan criteria, it's curable. If you don't meet it, it's not curable. So they did work. It did work, and they found 80% of the tumors when they could be cured. But they also found that 3/4 of those lesions were not cancerous lesions. They were indeterminate. They couldn't tell whether they're cancer or not, and they required further imaging. And 11 of them had to even have a liver biopsy of that lesion. And then of those ones that had a biopsy, about half of them turned out to be cancer, but half of them didn't. So it means that you're going to have some false positive imaging, and that may lead to cost and potential harm if they have to have a biopsy. So we do need in the future to have better serum markers for liver cancer and better radiographic techniques to say this is a cancer, 90% this is a cancer, and 10% that it's not. And next slide. So again, the practice guidelines say if you have F3 or F4 fibrosis, liver ultrasound AFP, and then if you find a suspicious lesion, you want to go next to do a quadriphasic CT or an MRI. Next slide. Now here is the CT you want to order. You can order as multiphasic, quadriphasic, triphasic. Just don't order a regular CT scan. So over on the left-hand side, you see that on the top, that's a non-contrast CT scan. Can you see a tumor in there? There's a lot of little hole-looking things, but can't tell for sure whether it's a tumor. If you look at the bottom left-hand slide, that's the usual contrast picture that the radiologist will take. And that is taken 45 seconds after the dye is injected in the patient's vein. And that reason for that is that about 80% of the blood supply that goes to the liver doesn't come from the artery. It comes from the portal vein through the gut. So when you give the contrast, it's got to circulate all the way around through the liver, through the heart, and then go into the liver through the portal vein. And that takes 45 seconds. Turns out that 90% of liver cancers get their blood supply from the hepatic artery. So they will not light up very well on the contrast phase. And you can see where the arrow is, that's the tumor, but it's really hard to see. Now go to the top and go over to the right. That particular arterial phase picture is taken 10 seconds after the dye is put into the liver. And look at that cancer. It pops right up like a light bulb. And it's right there. A small tumor, easily curable, easily burned out with radiofrequency ablation in 15 or 20 minutes and cured. But that would be missed if you ordered a regular CT scan. And if you don't say you want a multiphasic, quadriphasic, or triphasic, the radiologist is going to get you a scan that's going to miss a lot of tumors. The delayed phase in the quadriphasic is a 2-minute delayed phase after the contrast has been injected. And sometimes in the delayed phase, you can see that the tumor, even though it's washing out, there's a rim of brightness around the tumor because the contrast stays in the capsule of the tumor a lot longer than it does in the tumor. So just to reiterate, when you see when you do a triphasic or quadriphasic CT scan, you see that on that arterial phase, you don't see anything in the liver except the tumor. And when you get to the portal venous phase, when the liver lights up, the tumor is washing out. And when you get to the delayed phase, everything is washing out in the liver, both the liver itself and the tumor. So just remember this when you order a CT scan, if you really want to find tumors. Next slide. So how good are our techniques? Well, finding small tumors, the ultrasound is effective about 46% of the time. For tumors less than 2 centimeters, it's 21%. And then for 2 to 4 centimeters, it's 62%. And for greater than 4 centimeters, it's 85%. CT is much better, 40% for the smallest tumors, 80% the next group, and 100% for people that are more than 4 centimeters. And MRI is a little bit better than CT, but pretty much about the same. Next slide. So you can cure these tumors with something called radiofrequency or microwave ablation. I'll show you what that is. All you got to do, you find that small tumor like that picture of that CT scan, bring that patient into the ultrasound suite with an interventional radiologist or a surgeon. That's give that patient conscious sedation like you would for a colonoscopy. Under ultrasound or CT, you put a needle into that tiny little tumor and that's hooked up to a radiofrequency ablation machine, and you burn that tumor out. The patient is observed for an hour or two afterwards, and out the door and home and back to full activity with a potentially cured cancer in 3 days. And so that's why you want to find these tumors early. If the tumor is way over on the left side, up against the diaphragm, for example, they may have to have a laparoscopic ablation, and that means overnight in the hospital, back to full activities in a week, as opposed to a surgical resection, which is a week in the hospital and a month of their ability to go back to full activities. Now, once you can cure these tumors 3 ways, either by that ablation, by surgical resection, or by transplantation. You can't cure them any other way, but there are other treatments. One of them is called transarterial chemoembolization, or TACE. That's where you put a catheter into the hepatic artery that feeds the tumor. It's done by interventional radiology. The radiologist then shoots in some chemotherapeutic agent, either adriamycin or cisplatin, and then they clot off the vessel. And that clot is a temporary clot. It causes an ischemic insult. It keeps the chemotherapy in the tumor a lot longer. Then you end up with a double kill, the ischemic kill and the chemo kill. And it can't cure those tumors, but it can reduce the size. And sometimes it can take a 7 or 8 or 9 centimeter tumor and reduce it down to 5 or 6 centimeters and make the patient eligible for liver transplant. Another way of doing it, which is just as effective, is called TAR, or transarterial radioembolization. Same technique, except you're putting in yttrium-90 radioactive beads into the artery that goes into where the tumor is, and then you clot it off. Now, we've got a lot of new drugs that are coming out. You probably hear about them. They're oral pills, and they don't work very well, as I'll show you in a minute. But they are the first chemotherapy that works. Regular chemotherapy, like cisplatin and all the other stuff, does not work in liver cancer. It does not prolong survival. Next slide. So ablation and cervical cures for hepatitis B, when they don't have cirrhosis, maybe at higher cure rates than in hepatitis C where there's cirrhosis. And the other thing about in hepatitis B is that we want to be sure we suppress the virus if they have viral replication going on. Next slide. So here's the size of the tumors we want to find. We want to find the tumors when they're 1, 2, or 3 centimeters, because we can easily cure them with resection, transplantation, or what we use in our hospital, microwave or radiofrequency ablation. And when they get to be bigger than that, then they've got to either be surgically removed, or if they're bigger than that, we can sometimes shrink them down with TACE, TAR, and then they can be transplanted. And then when they're really big, or they're in both sides of the liver, basically they're not curable, and it's basically trying to prolong their life with mostly the way to prolong it is with repeated TACEs and TARs, and then it's palliative treatment after that. Next slide. So here's a tumor. This patient, Alaska Native patient, gave us permission to show this picture. This is a hepatitis B patient who doesn't have cirrhosis, but a strong family history and a very toxic genotype F, that causes liver cancer in children. And we found this tumor in him when it was 2 centimeters, and when he was 17. It was resected. We didn't have treatment for viral hepatitis B then. We went on and got cirrhosis about a decade later. We got treatment, we treated him, he got a recurrence, and then he ended up with another cancer, but he's in his 40s now, and he's got 4 kids. He's a school employee in his community, and he wouldn't be alive now if it wasn't for the fact we found that tumor when it was 2 centimeters. Now we just burn it out with radiofrequency ablation. Wouldn't have to operate on it. Next slide. If you want to find these tumors early, now I don't know if you can get this to work, but here's radiofrequency ablation in its 3D action. So you want to give it a try, Ashley? If you can double click on it and see if it'll work, or did you try it and it didn't work?
Hey, Brian. Yeah, we did try it over here and it wasn't working. But just to make sure everybody gets this information, the PowerPoint will be going out so they can try it at home as well.
Yeah, so the way you can do it is if you have Microsoft program on your computer, just download the Microsoft Imaging program, and it's for free. And then you can double click on that. It'll show you radiofrequency ablation, how it's done in a cartoon, not in a human being. Next slide. So again, we talked about radiofrequency ablation. Now, let me just pop down to liver transplant. A patient's eligible for transplant if they have 3 or less lesions, all have to be in one lobe, in both lobes. The total diameter of the 3 lesions has to be less than 7 centimeters, with the largest one less than 5. So if they're all in one lobe and there's like a 7 centimeter or 8 centimeter lesion and there's more than one, you can shrink that 8 centimeter lesion down with TACE or TAR to get it below 7 centimeters and the total diameter of the lesions, and then they're liver transplant eligible. How well does liver transplant work? 5-year tumor-free survival is 70% with liver transplant. That's pretty darn good. So liver transplant is an important method, but it's expensive and of course a burden to the patient. Next slide. Now we got all these drugs coming out. They're all oral pills. They're checkpoint inhibitors and FX inhibitors, and you can see that they don't work that well. So look at the underneath median OS survival. That's median survival, and this is versus placebo. So you can see 10.7 months versus 7.9. What is that? 3 months? 3 months, 4 months, 2 months. And these drugs, even though they're once a day oral, sounds great, they have tremendously horrible side effects. Nausea, vomiting, Stevens-Johnson syndrome. And we've treated 3 patients and they all threw in the towel with sorafenib. We turned it over to oncology and let them work with the patient to decide whether or not they want to get these drugs. We just don't have good drugs that can cure or give these patients quality additional time, like we do for breast cancer and for cervical cancer and for colon cancer, pancreatic cancer even. We don't have those drugs. So you got to find these tumors early and get rid of them by ablation or remove them. Next slide. Okay, so there is some really interesting things that have come out with secondary prevention. In other words, somebody has got cirrhosis and you know that they're going to with a 1 to 3 to 4% chance of getting liver cancer per year. And what can you do to maybe decrease that risk? Well, if they have hep C, cure them. If they have hepatitis B, put them on antiviral therapy and knock the virus down. That really decreases the risk. But there's some adjuvant therapies that look like they might work, and I'll show you some data. Coffee, believe it or not, statins, and aspirin. Next slide. But here's a study of looking at aspirin a day in a large group of patients, looking at people who retrospectively were at risk for liver cancer, hepatitis B and hepatitis C, and were taking aspirin for any reason and took it for at least 3 to 4 months, more than 90 days. They had a much decreased risk over time of liver cancer than people who had never taken aspirin. And the next slide. And here's a study on statins. It was just published in the Annals of Internal Medicine 3 weeks ago. And this is the poster that was presented at the liver meeting, but you can actually look at the whole article. They looked at, in Sweden, with national registries, everybody has to have all their information, including the drugs they take, in a national registry. And they showed that if you take a lipophilic statin, such as atorvastatin, versus a hydrophilic statin, such as pravastatin, you can really reduce the risk of liver cancer over people who have never had a statin before. So it's worthwhile thinking about that, especially in patients with NAFLD. Make sure they're on a lipophilic statin. Next slide. Coffee is more than 50 studies showing that coffee decreases, slows down the scarring in the liver, including a classical NIH study of 2,000 people who got with Hep C and advanced fibrosis cirrhosis, who got liver biopsies every 2 years for 6 to 8 years. The only thing that slowed down their scarring, reduced their risk of cancer, was coffee. And it wasn't caffeine, it was coffee. And there's something in coffee that really does work. It's in the bean, so decaf or caf. We send letters out to our patients and tell them drink coffee. In one study, the reduction of risk of cancer was 20% in those who drank 1 to 2 cups, and greater than 75% if they drank 5 cups of coffee a day. Most patients like to hear that, so tell them that. If they drink coffee, please keep drinking. Next slide. So in conclusion, we want to identify patients at risk for liver disease, screen for diagnosis. I might mention that it's estimated by the NHANES study that 25% of Americans have non-alcoholic fatty liver disease, and 1 out of 5 of those have the form of NAFLD called NASH, which progresses onto scarring of the liver and cirrhosis. So everybody that has a metabolic syndrome needs to be worked up for the possibility of having underlying liver disease. Identify in those with underlying liver disease the level of fibrosis, and if they have F3 or F4 fibrosis, initiate surveillance with ultrasound and AFP. Remember, there are significant limitations to our screening modalities, so keep a high level of suspicion. And detecting liver tumors can lead to long-term survival. And hepatocellular carcinoma that's advanced too big to ablate or transplant is ultimately fatal. There is no chemotherapy or cure that is available currently at this time. One more slide, I think. And surveillance to detect tumors is beneficial, and although the benefit is moderate, we need better radiographic and biomarkers to detect cancer early. And we think we can combine risk factors and come up with better algorithms for surveillance. We're working on that right now. We need better treatment modalities. And remember, it's better to try to prevent liver cancer, so vaccinate against hepatitis B, identify hepatitis C, and treat those patients with hepatitis C for cure before they get cirrhosis or advanced fibrosis. One last thing I want to mention is that I know that a lot of you are treating hep C and curing hep C, and you're done with those patients if they don't have F3 or F4 fibrosis. But if they have F3 or F4 fibrosis, you've reduced but not eliminated the risk of liver cancer, and they do need ongoing surveillance. And I think that was my last slide. So we can answer questions or take any comments now at this time. I think we have about 10 minutes.
Yeah, thank you, Brian and Mary, for all that really valuable information. We did have a question come through, and I believe you answered it, but I'm going to ask it again. If a patient is diagnosed with liver cirrhosis, is there any effective method to treat and reduce their risk of liver cancer?
Yes. So basically, what we've learned, believe it or not, when I was in medical school, we were told that if you get cirrhosis, it's all over. You got cirrhosis. But cirrhosis can reverse if it's early. So if somebody is drinking alcohol, for example, they get early cirrhosis. And if they stop drinking 5 years later, half of them will not have cirrhosis anymore. Same with hepatitis C. Half of the people with hepatitis C with cirrhosis that had a liver biopsy in the initial trials, 5 to 7 years later, the cirrhosis was gone. and they had some scarring, but it was improving, and it probably would continue to improve. Same with hepatitis B. So in other words, you can reduce cirrhosis by treating the underlying disease. In addition to that, there's a number of drugs that are in clinical trials now looking to see that they might reverse cirrhosis. For example, one drug that's already licensed are the class of drugs for diabetes called the GLP-1 or GLT-1 drugs that are also used for weight loss. Those drugs actually are in clinical trials now. The preliminary trials suggest that they have antifibrotic action in reducing scarring in the liver. So we'll have to wait and see if that works. But there are a number of drugs that potentially could repair cirrhosis. But if cirrhosis is very advanced with lots of nodules, it's probably not repairable. Any other questions or comments? I might mention that why is alpha-fetoprotein in there? It's really the only marker that we have, and it's not a great marker. It has very good, if it's very low, it has a 90% negative predictive value. And if it's very high, it only has a 10% negative or positive predictive value. So just for example, we saw a patient yesterday that is hepatitis B, and he doesn't have cirrhosis, but he has that bad genotype. And there's this funny little spot in his liver that it's about 1 centimeter, 1.5. It's pretty small, and we can't really tell if it's cirrhosis or not. But his alpha-fetoprotein went from 5 to 200 over a 6-month period, and it turns out that when we do a quadriphasic CT scan, it's still not completely diagnostic, but it's very suspicious for liver cancer. So we're about 90% positive that this guy has liver cancer. So he's coming in for a radiofrequency ablation for a tiny little tumor that is very easily curable. And we're lucky we found that tumor early, but the alpha-fetoprotein really helped us a lot because we might have passed that lesion up that was just very small and kind of indiscreet. So that's why alpha-fetoprotein is in there.
Thanks, Brian. You're getting a lot of interesting comments about the coffee information and the benefits of drinking coffee. So I put that slide back up for everybody. But we did have another question, and we have a few more minutes yet left to answer. So in your patients with liver transplant, how well do they do? How long does it take for patients to get a liver transplant, and what is the survival rate post-transplant?
So if in order to qualify for liver cancer transplant, then everybody in the U.S. has agreed on the Meld system. It's called the Mayo Clinic In-Stage Liver Disease System. And we always use that to calculate the Meld score in our patients. It's really easy to do. Again, you just put Meld into your search engine, and you'll get up. It'll pop up with Mayo Clinic In-Stage Liver, and then you click on it and you put the numbers in of their labs. But the thing that the Meld system has done is added an extra 3 to 5 points for people with cirrhosis who will need a liver transplant if they have liver cancer. A small liver cancer will get you extra Meld points. Now, if you've got a small liver cancer and you need a transplant, you'll get about you'll get a 90% 1-year survival from a transplant. You'll get a 70% 5-year tumor-free survival from a transplant. So a transplant is a very effective way of treating liver cancer. I mean, 5-year survival for any cancer of 75% is pretty darn good. So basically, liver cancers don't spread very, very often outside of the liver. Even when they die from liver cancer, only 50% of patients have liver cancer outside the liver in the lymph nodes or in other parts of the body. So it stays in the liver, and that's why liver transplant works. But you have to have it all in one lobe for the liver transplant to be as effective. If it's bilateral, then the survival rate is like 20 or 30%, and so they won't qualify for a transplant.
Thanks, Brian. And one last question. Can either you or Mary speak a little bit more on the ways that you connect with your American Indian and Alaska Native patients that you see?
Sure. I think it's an important question given how sensitive some of these topics are that we need to watch out for development of hepatocellular carcinoma, and particularly NAFLD. People who are have weight problems, are gaining too much weight, and then also alcoholism, of course, and even hepatitis. So the most important piece that I teach all the students, or the medical students here, is developing a relationship, because otherwise your patient's not going to talk to you at all. So going in and meeting the patient on their level, considering using motivational interviewing or trauma-informed care to develop that relationship with your patient, make it a safe space where they feel not only safe in talking to you when they're there, but coming into the clinic in the first place and seeing anybody, because we're not going to get anywhere with any of these diseases if we can't get the patient in the office and get them returning for care. That's the primary piece for me. Brian, do you have anything else to add?
Yeah, so absolutely, that's the most important. But what we do to enhance the chances of finding these tumors early is we put everybody that is at risk into a database. We use a Microsoft Excel and Access database, and we send them a letter every 6 months to get their blood drawn, and if they have cirrhosis, a reminder letter to get an ultrasound, try to get an ultrasound. And we send a list of the patients to the patient's provider, and to the local clinic, even if it's a village clinic. And then we just keep doing that every 6 months. And we also feed back the results of the patients. Send them a lot of information, educational information. We have a website for patients to click on and go through stuff. And we try to see those patients on a regular basis. It's not easy when they're living all over the state in small little communities, but we try to get them in once or every year or two to see them and do exactly what Mary is saying to do. So that's really an important communication with your patients, and finding a system that works for you so that you can send reminders to your patient. It could be an app, a tweet, whatever you want to use to tell them you're due for your surveillance, just like we do for colon cancer and breast cancer. It's time for you to come in and get your surveillance for liver cancer done.
Hey, Brian, I'm curious if you guys have looked at your return on the work that you've done as far as sending out the surveillance letters and sending out letters, lab letters to any patients with elevated LFTs. Did you measure before and after you started the programming?
Well, we never measured before, but we could look at what the national averages are. So, for example, in the VA system, 5% of people with cirrhosis get an ultrasound every 6 months. That's pretty dismal. They actually copied us and started sending out letters, and they were able to bump it up to about 15%. And then they also added in a study where they put in a patient navigator to contact the patients, and that raised it up to about 25%. Well, we're at about 50%. 50% of people come in at least once a year for surveillance for liver cancer with either an ultrasound, a CT, or MRI. It's not every 6 months, but it's once a year. And we find about 50% of our tumors at a potentially curable stage. About half of those are only curable by transplant. Half of those we're able to burn out with radiofrequency ablation, occasionally with surgery, using surgery. So it's better. I think we're better than the national averages, but it's a long way to go, because you don't want to have just 50% of people have their tumors found early, and then half of those you can only transplant them. It's not easy to get a transplant. For every person on the list, every 3 people on the list, only 1 ends up getting the transplant because of the shortage of livers. And again, that transplant is not based on race or ethnicity or anything else. It's based on Meld score points. That they did it to make it ultimately fair, but it's in a way it's kind of a little bit of a cruel cutoff. If you don't have this many Meld points, you're not going to get a liver transplant.